Good morning, everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here in Insurance Syndicate headquarters, and man, we have a great show for you.
Good morning, good morning. Why does it keep starting me off with that goofy little inset instead of going me full camera? Hope everybody's doing great, man. Happy Tuesday. Happy Tuesday. If you tuned in for some Medicare news, well, you showed up to the right place because there's plenty of it. Seems like lately there is a nonstop barrage of Medicare news. I know normally this show has been, while it's been dedicated to keeping you guys up to date on some Medicare stuff, a lot of it has been, geared towards talking to other people in the insurance industry and actually covering like tactical training topics. But Medicare has been so wild in these last 9 to 18 months. This show has definitely been centered around that space, doing my best to try to keep you guys up to speed. So I hope you're having a great Tuesday. I definitely got some Medicare news for you. A lot going on, so I'm looking forward to jumping into it. As always, big shout out to my partners over at DFY for helping making this show possible. I was talking to a couple of agents recently who were starting to work with DFY and just absolutely enthralled and ecstatic about it. So easily one of the best go high level platforms out there to get your hands on. And a matter of fact, I was in my DFY platform yesterday. Check this out. I was working on our webinar package that we're putting together and rolling out. So far, so great. And then I noticed a piece of done for you content that was sitting in there that I had somehow overlooked. Maybe I don't know if the guys over there had announced it and didn't say nothing, but I saw this DFY funnel that was in there, done for you, meaning it's already built. All you got to do is plug your assets in, which is one of the reasons I love DFY. And they had a whole multi-video course funnel already built. So basically, for example, you could take a course on Medicare, right? Original Medicare, maybe a deeper dive into Medicare supplements, a deeper dive into Medicare Advantage, or any other course that you might want to create. It's already built for you. Completely built. All you got to do is plug in the videos, plug in your assets, boom, bang, pow, it's ready to go. So we're going to be rolling that piece out. We're going to be pushing that to our groups that we're working with. Like one of the things that we do over here at Avila, obviously we focus on the bilingual market. I'm going after groups, right? Companies that have large groups of bilingual Medicare beneficiaries or people that are aging in. So using that pre-built course funnel that they've got inside of DFY, where all I've got to do is plug in some of our videos, connect the dots on the assets and the conversion pieces, call to action. Dude, that thing is going to go lights out. All I got to do is get in front of all the different HR administrators, et cetera, that work at these companies. So with that said, if you have any connections, any referrals for me in the manufacturing, engineering, assembly areas, construction areas, I would be highly interested in talking to those people to see if they do indeed have a lot of bilingual folks that are turning 65 in their group that they can refer us to. We're already working with about 3 different groups out of Chicago that are in that space. One of them, just to give an example, works in they assemble and they manufacture and assemble the safety water systems for people that are working in chemical environments like eye wash stations, emergency showers, all of that. I got to tour their facility. It was really, really cool. But they refer us a couple of people every year that are turning 65 in their space that speak Spanish, need some help. Just picked up another referral for about a company of about 2 that estimates they have about 250 Hispanic people, bilingual people, Spanish-speaking people in their entire company that will slowly be aging 65. And they had a few ready to go now. So we're going to be doing a live webinar for them here pretty soon. But I'm excited to roll that out. But with all of that said, let's jump into a wee bit of news, get this show moving along. Bear with me just a moment. Some of these pop-ups that are in here are pretty ridiculous on these pages. You may have seen this. Make sure it's on screen for you real quick. There is a new bill regarding Social Security taxes coming out. Assuming that it gets passed, it would tax higher earners to help cover some of the Social Security and Medicare shortage, if you will. If you're in the Medicare space at all, you've been hearing about this for a long time. They won't stop talking about it, right? And it seems like pundits on either side are saying this stuff where Medicare and Social Security are close to going bankrupt, right? And we've heard several dates, like I've seen dates that range anywhere from as early as next year to like 2034, for example. And they're saying if we don't shore this up quick, raise taxes, for example, to collect more money or cut spending, right? Depending on which side of the fence you might be on, we are going to run out of money. And well, nobody wants that. So one of the thoughts they've come up with is this here. Real quick, do me a solid. Make sure you can hear me. For some reason, my sound just went out in my headphones. So if you can hear me, just drop a comment for me. I'm watching the comments. Say, yeah, we hear you loud and clear. I don't know why my internal sound dropped, but not that I need to hear myself, but it helps me kind of monitor. But anyway, they've got this new bill coming out that will increase, if it's passed, will increase taxes for people earning more than $400,000 a year, right? Fairly simple. I don't know why this little thing is stuck on there, but I'm just going to go over the basics of it right here. It says this bill would impose payroll taxes on earnings above $400,000, an income segment that is currently exempt due to the existing tax cap of $168,600. Right. So under the current law, workers and employers each pay 6.2% into Social Security up to that cap. Right. And then all wages are subject to a 2.9% Medicare tax. But this new legislation, if it's passed, would eliminate the Social Security payroll tax exemption on high earners or higher incomes, creating a gap between $168,600 and $400, where those earnings would still remain untaxed, but then it would pick up again for people over 400K. I'm all for that one, man. That would affect me, right? Not trying to brag, but that would affect me, and I got no problem kicking a little more money to make sure that that system is solvent, right? Progressives and senior advocates here, it says, have praised the bill as a fair way to sustain critical benefits without hurting the middle class, right? Organizations such as the Center for American Progress note that applying payroll taxes to income over 400K could close nearly 80% of Social Security's funding gap. A 2023 Pew Research Center poll also found that 68% of Americans support increasing taxes on high-income earners to protect Social Security Medicare. Absolutely. I'm all for that one. Stay tuned. I'll do my best to keep you guys informed if that does indeed pass. They didn't list the name of the bill in here that I caught, but there is a bill up there in that space where they are going. Oh, as a matter of fact, here it is. It's the Social Security Medicare Fair Share Act, aptly named. Let's move on because I got a fair amount of news for you guys today again. Because, like I said, it's not stopping. We all know that drug price negotiations have been going on for a while, and now they are looking at adding Part B drugs to those negotiations. Right? It's generally been specific to prescription meds, Part D meds, right? That you go into the pharmacy, turn in your prescription, you get them. That's what all of the drug price negotiations have been targeting. But now they're saying, hey, we want to add Part B into that negotiation program. So the Trump administration has issued new draft guidance for the third cycle of Medicare drug price negotiations. The proposals seek to boost transparency in the Medicare program and put a focus on negotiating for drugs that come at the highest cost of Medicare. The agency is also aiming to avoid negative impacts from negotiated prices, right? But under the guidance, drugs administered under Medicare Part B would be potentially included for the very first time. Right now, they are looking for feedback and comments on how to manage access and the maximum fair price negotiated drugs. So pretty simple piece there. When I think about that, when I think about, some of the people that I'm going to say people that are getting Botox injections, people that are getting certain cancer meds where they do have to go in and get them covered by Part B. I don't know if those are on the list, and I certainly don't know all of the Part B drugs. There are some very, very pricey ones out there. I can see how that can be very advantageous for them. So we will see how that works out as well. Moving along, more new stuff coming. More new stuff coming. Downside risk and upside payment highlight a new CMS innovation agenda. This is pretty interesting, but they are basically looking at pretty much changing the entire, platform in regards to how they handle claims, risk management, etc., accountable care organizations, that whole bit. So check this out. So Center for Medicare Medicaid Services is rolling out a broad new agenda for its innovation center that could lead to requirements for participants in value-based care to take on some of the downside risk. The Center for Medicare Medicaid Innovation Plan prioritizes shared risk and prospective payments, streamlined quality measurement, artificial intelligence, and other technologies under the Medicare Advantage payment models. So notably, I'm just going to go through this article pretty briefly in a few key points. Notably, CMS is walking away from a goal set 4 years ago to have all fee-for-service Medicare beneficiaries under accountable care arrangements by 2030. I don't know if you guys knew about that goal, right? A lot of people talk about the changes that are happening in Medicare and, oh, so-and-so is trying to privatize Medicare and Medicare supplements, this is happening to them, and Medicare Advantage plans this and that and pull back. And I have been saying this for a few years now. All you have to do is go back and look at legislation starting in 97. Look at every piece of Medicare reform starting then, and there has been an absolute bipartisan goal to move people into privatized versions of Medicare. And one of the original goals they had in 2016, if I remember correctly, I'm going a little off of memory of that, was to get, at that time, I want to say it was 30% of people off of fee-for-service Medicare. Like, they wrote legislation specifically with the goal to get at least 30% of the people off of fee-for-service Medicare and into privatized arrangements, accountable care arrangements, etc. Their goal here says by 2030, they want 80% of people covered by fee-for-service Medicare moved into accountable care organizations. That's your ACOs, that's various MAPDs that are hooked up with VBC or value-based care clinics, etc., right? That's where they want to go. They've been wanting to do this since 97. It's been a bipartisan arc that's been happening every few years. So while they go on to media, and one side of the political platform is saying, oh, they want to privatize Medicare and take away your Medicare, and the other side is saying, no, we don't. We just want to cut spending. We're not taking it. They all want to take away your Medicare to some level. They want to take away fee-for-service. They want to get rid of the fee-for-service program and move everybody into a privatized accountable care arrangement by year 2030. So when I tell you that it's a bipartisan, by design plan to wreck original Medicare and drive people into ACOs and MAPDs and private Medicare arrangements, 100% both sides are playing that game, and they're using you and their bullshit rhetoric, pardon me, for your votes. It's fairly simple, but both sides want the same thing, and it doesn't take much to go back and look at it. So understand that this is something that is being pushed. This is an agenda that is constantly being pushed, and every time a new administration comes in, they'll take some piece of the movement of that arc and move it a little bit forward through some guys, right? They might not take the whole thing that the last administration teed up for it. They're like, no, we don't want that. We don't want that. But we definitely want to continue the drive towards privatized Medicare. And I don't know how anybody could not see that, because the amount of information that is out there telling you that they are trying to wreck original Medicare and make it less attractive and move people to privatized versions. This right here. I mean, it says they're walking away from a goal to do that. I don't know that they are, maybe, but I don't think this is 100% true when they say that CMS is walking away from a goal set 4 years ago to have all 100% fee-for-service Medicare beneficiaries under an ACO arrangement. Now, maybe they don't want them all under an ACO, right, an accountable care arrangement, but I guarantee you they want the vast majority of them in large swaths moved into a privatized version of Medicare. Guarantee it. Moving along, this new CMMI, that's Center for Medicare Medicaid Innovation. This new CMMI plan aligns with broader goals espoused by Health and Human Services Secretary RFK Jr. and CMS Administrator Dr. Oz, who have accentuated preventative medicine and chronic disease management. And this is the first major effort by the still new administration for Donald Trump to put his stamp on Medicare. The Innovation Center has made investments in the necessary infrastructure for broad system reform. And our vision is to take the learnings from these investments to build a health system that empowers people to thrive in their own again, make America healthy again. CMMI will design ACO models and other value-based programs to promote nutrition, tobacco cessation, and encourage screenings for ailments such as colon cancer, interventions to maintain people with conditions such as diabetes, right? The thing is, they are wanting the people in the VBC space to take on some of the risk, the downside, not just participate in the upside, right? They haven't gone into a ton of how they plan to do that, but it says it right here, designing models that require providers, doctors, clinics, hospitals, etc., to at least accept some downside risk could be the most consequential action stemming from this plan. Subjecting participants to potential financial losses, not just potential benefits, is key to driving cost and savings and quality improvement. There should be downsizing models, he says. What I want to do is aim the maximum number of people in value-based care arrangements that involve downside. Fairly interesting. I'm going to drop this in the group for you guys. It's a fairly lengthy one. I will likely be following up on this article and the updates on this new platform that they're overhauling for ACO and how they plan to do it. We're headed for some interesting times. And I think ultimately, hopefully in a good side, we'll see. But this right here, this new CMS innovation agenda is really going to play out interesting. I will definitely get that in the group. You guys can check that one out. And we are going to move on to a couple of other items. And I'm going to support my argument a little bit with this news right here. Delaware lawmakers look to expand Medicare supplement enrollment period for seniors. Big title, big headline for something very simple. They're adopting the birthday rule. That's another state adopting the birthday rule. A couple of weeks ago, I went through a list of, I want to say 16 or so states that either already had the birthday rule, or no, didn't even. Those were new states that were being added. I'm sorry. It didn't include California, Oregon, and Missouri that have their versions of the birthday rule. But it had 16 new states that are all adding it or have already recently added it. Why is that a problem? Hey, it's great for people. I get it. It's really good for beneficiaries in one side because it allows them, if their Medicare supplement plan has gone up in rate during the 30 days or in some cases 60 days that surround their birthday, they can flip their Medigap plan with no questions asked, right? And sometimes there are some restrictions, like if they're in Plan F, they have to stay in Plan F, or they can maybe downgrade. But if they're in a Plan G, they can't make that change and step up their plan to like a Plan F or Plan N to G and so forth. So some of those little tiny variations will vary from state to state. But ultimately, we know that any time, unless you've been living under a rock, if you've been in the Medicare supplement space for a while, I've been in it for 21 years, any time that they adapt or adopt the birthday rule in a state, rates for everyone in that state go up. They have to, because now they can't underwrite and reject people that bring a lot of claims. So you can't keep the book of business clean. It's going to be dirty. It's going to have claims. And in order for them to stay solvent so that they can pay those claims, rates have to go up. This isn't a matter of insurance companies gouging people and taking advantage of them. This is a matter of insurance companies trying to maintain profitability against legislation that forces them to take on more risk. It's a fairly simple concept. Like, it's not a hard math equation to put together. So here is yet another state adding the Medigap rule. And when I said this reinforces my argument that I believe there is a large bipartisan design to make original Medicare less attractive so that we can get everybody into ACO models, into MAPD plans, ultimately as a, call it a direction towards universal health care. This is just more evidence of it, right? If they can get everybody, because they're doing it under the guise of inclusivity. Let's make sure everybody's included. We don't want anybody left out. We don't want anybody not to be able to get a Medigap plan. So in order for everybody to have access to one, everybody has to pay much higher rates. So now that those rates are that much higher, they're that much less affordable for some folks. And so they're just going to gravitate to a Medicare Advantage plan instead, especially if they can find an area like California, Florida, and some of these areas where you got MOOPs that are $1,000 or less. Like, give me a break. Why in the world would you buy a Medicare supplement plan in those areas? Doesn't make any sense from a cost or mathematical standpoint. So again, here's just more evidence that they're going after it. So they don't say exactly when this is going to go into effect, right? But Delaware is drafting the legislation, and they are going to do a 30-day birth or a 60-day birthday rule. 30 days before, 30 days after, right? Just got introduced by Democrat of North Brandywine, State Senator Ray Siegfried. So it said it would make it the 11th state, but that is not correct. I believe there are more than that. I think I want to say there's as many as 16 that are either in the process of adopting that rule or not. I can go back and pull that list for you and we can address it again. But that list is growing at a rapid rate. And if you think of it, like unless they can find a way to reduce the cost of original Medicare, Part B specifically, then yeah, it's going to get harder and harder to sell Medicare supplements because they're going to become more and more, they're going to become less and less affordable. I mean, fairly simple. Moving along. We've already heard about this one. It dropped yesterday at 9 a.m. Trump dropped another executive order that he calls the most favored nation policy for pharmacy prices. A lot of people already have a ton of opinions, of course, because that's what we do here on the interwebs, is we see news and we slam it with our opinions. Right? So on Sunday, President Trump posted to Truth Social that he planned on implementing a most favored nation policy for pharmaceutical drug prices. And I'll just read his little clip here. For many years, the world has wondered why prescription drugs and pharmaceuticals in the United States of America were so much higher than the prices in other nations, sometimes being up to 10 times more expensive for the exact same drug manufactured in the exact same laboratory or plant by the exact same company. Does seem a little bizarre, but theoretically, aren't we one of the richest states or nations out there? I don't know where to stand on it. Certainly, I hate that I see my beneficiaries having to pay ridiculous cost, especially for some of my beneficiaries that are truly just living on their Social Security stipend. Like, it's ridiculous. So yeah, I can hopefully use the cap and help them, but even then, like, sometimes it's a big issue. So he continues saying that he plans on signing the executive order, which he signed yesterday at 9 a.m., that reduces pharmaceutical drug prices. According to his post, the order will impact drug prices by 30 to 80%. It goes on to say it's unclear how broadly Trump plans to extend the impact of the executive order. The government is set to negotiate Medicare prices, but the wording of Trump's post does not make this specification. Additionally, Trump also states that drug prices may increase in other parts of the world to make them fair with American prices. Part of me really appreciates his intention. Hey, we need to drive down the drug costs for the beneficiaries here in America. But if we do it by attacking the other countries and making them pay higher prices, like, what's to stop them just from saying, okay, fine, everybody gets to pay American prices for drugs? Now you're all screwed. What would prevent him from that? There's nothing that I've seen, and I've gone through this, that doesn't allow something like that, where they just, and it even says it in this article, like prices in other parts of the world might just go up to make them fair with what America is paying. So instead of getting America lower prices, he might end up getting everybody around the world higher prices. Don't know. But he's given them a cutoff. I believe it is May 30th to agree to this. Otherwise, there are buying limits that he's putting on the pharmaceutical companies as far as how much they can, or how much they will get, or such. I don't know what those limits are, but he's threatened that hey, if you guys don't adopt this by, I want to say by May 30th, there will be problems. So I appreciate the intentions. I don't know if it's anything for us to really worry about. I would say it's just something to pay attention to, right? And see how it goes, see what happens, because we already have drug price negotiations going on. They're looking at adding Part B drugs to those negotiations. So I'm not really sure how this goes. But if you haven't heard and you don't really know what that means, the most favored nation policy, basically what that means is Trump wants us to pay the same price as the cheapest price out there, right? So whatever country is getting the best deal on Mount Jaro, like he wants us to have that same one, right? Don't know that that's necessarily fair, but I don't know I don't know what every country is paying for drugs, but I would say I would agree that it's not fair for us, that if they're paying $5, why are we paying 5,000 or whatever that disparity might be? I get that, but I don't know how this is going to work out. It's going to be an interesting. So keep your eyes peeled on that. And here's some more opinions on it out of Newsweek, right? Pardon me. But this one says, could prescription drug costs change for Medicare users? Experts weigh in. So we already know that has been out there, right? Gerald Anderson from the Johns Hopkins Bloomberg School of Public Health says, our published research shows that Americans pay on average 3 to 4 times for most brand name drugs than what people in other industrialized countries pay. And for some brand name drugs, it's 100 times more. So this is where I'm saying, like, there's definitely an issue that we're having to pay this much. But if it comes down to where all these countries just end up getting their prices jacked up to make it fair, that's really not what it's about. Mark Figler put a comment in the chat that it's about RX manufacturer and advertising and marketing money. And dude, I do not disagree. I do not disagree. In my opinion, if they told all the big pharma companies, you can no longer advertise on TV. I mean, if you hadn't already heard, there's only 2 countries in the world that allow big pharmaceutical advertising. It's us and New Zealand. Nobody else allows it. No one. Just us and New Zealand. Interesting. So what if they said, hey, you're no longer allowed to advertise on TV in the US? I would assume that's a pretty substantial savings. Because look at where they place their ads. You think the media companies are giving them ad space for free? No. I mean, they put their ads on some of the highest watch programs, channels, Super Bowl, sports events, everything. You're going to see Pfizer. You're going to see them in there. So if they said, hey, you can no longer do that, then doesn't that bear to reason that they could save hundreds of millions of dollars? Maybe billions? I'd love to know what their ad budget is at Pfizer for U.S. television advertising. I can't imagine how grotesque it is, right? Because we've seen the spots. So, I mean, I would say at minimum, hundreds of millions of dollars they could save. So if they could save hundreds of millions of dollars by not being allowed to advertise on TV, then couldn't they pass through that savings into the drug pricing instead? Isn't that how that works? I mean, I'm not an economist expert. I'm not, Thomas Sowell, but come on. That seems like a pretty standard idea there. But the fact that this dude is saying that our research shows that Americans pay on average 3 to 4 times more for brand name drugs than other industrialized nations. And sometimes it's even 100. See another expert opinion in here. While this would lower costs for 4 million Medicare beneficiaries who use Part B drugs, it wouldn't affect most people on Medicare or anyone with Part D. Who said that? I don't know that that is necessarily true. Well, so there you have it. I'll get this one up there as well. This one isn't as hyper informative. It's got a couple of quotes that it popped out. So nothing major there. And then I want to just leave you guys with 5 changes. I found this article, which is spot on. And I talked about this in the CMS final ruling, but this summarizes it pretty well. If you guys didn't see my video on the CMS final rule, it was pretty much a nothing burger. Like, truthfully, it was a good ruling for us as brokers and agents for the most part, because they didn't add any of the marketing friction that the previous administration wanted to add to us, right? They wanted to broaden the definition of marketing to include educational content, right? Which means that if you grabbed your phone, lifted it up, and were like, hey, the cost for Part B is going up, you would have to file that with CMS as approval and get approval to even run that as an organic or paid video that you can put on your channel. So I think the new administration saw the absolute administrative nightmare that would create and said, yeah, we definitely can't do that. So if you look at and just go back and look at my CMS final rule video. It was about 3 or 4 weeks ago, something like that. I'm not sure. But I talked about here's what they proposed, and then here's what got approved. And if you look at it, like, it's almost a nothing burger. They took out all of the marketing stuff, completely vacated new regulations put on brokers. They didn't reverse any of them. They didn't reverse call recording. They didn't reverse the 48-hour rule. They certainly didn't reverse the scope. They didn't reverse those types of things. But they didn't add any of the new stuff to it as far as marketing regulations that we were going to see. All of the stuff regarding TPMO to TPMO and commission structures and co-op dollars and HRAs and VBE payments and all of that, that's still kind of out there because there's still some lawsuits going on in that space. I'm of the opinion that's probably going to get vacated. However, if you go back and you look at last week's show, talking about the Trump DOJ suing Elevance, Aetna, Humana, eHealth, GoHealth, and SelectQuote, that lawsuit and investigation could uncover reasoning that might wipe out our co-op dollars. I could see them wiping out co-op dollars pretty soon. Won't be this year because they've already finalized their CMS proposed rule. So unless they can find some other little add-on to it, I don't think we'll see that this year. But perhaps next year, wouldn't surprise me to see marketing and co-op dollars 86th. Because it reasons to believe, if they're looking at this and they're saying, well, eHealth, GoHealth, and SelectQuote are all getting kickbacks and marketing money from Humana, Aetna, and Elevance to write their products instead of others. In other words, steering, which is against CMS regulations. So we have to get rid of that. But in investigating that, they might uncover that, and they already know this, that, well, brokers like Tony Merwin and Avila Medicare Solutions, like, occasionally they get $5,000 from Aetna, $10,000 from Humana as marketing money for AEP and OEP that they can use. And it doesn't take a genius to understand that Humana, when they give me that money, they are wanting me to write Humana business. Like, they're wanting me to steer people. I don't, and I don't care. I don't really need the co-op dollars. I know there are agents out there that really, really thrive and survive and need co-op dollars. I'm not here to argue with that and get them taken away from you. But if Humana's going to offer them to me, damn right I'm going to take them. I'm not an idiot. I'm going to take that $10,000 and throw it in my marketing budget. But I am not going to say, hey, all you guys, Humana gave us 10 grand. We're required to write 150 apps with them. So I need y'all to prioritize Humana. No, not going to do it. I'm in it for my beneficiary in the long game. I'm trying to make 5-year money, not first-year money. So if by next year, Humana's like, well, you didn't write the number of apps that you said you were going to write, when we gave you that 10 grand, but we can't give you 10 grand anymore. I don't care. Don't give me the money. Now, if they hear this, I'm probably not getting any AEP money next year. But anyway, 5 changes coming to Medicare in 2026. I've already talked about this in my CMS final ruling, but we're going to run over it. Nothing major, I promise. But good information nonetheless. Not going to go through the whole article. I'm just going to jump right to the 5 things. And they are all based on codifications of the Inflation Reduction Act. Okay? If you go and you look, and this was wild in some level, because there was a bunch of people, as always, pontificating, yelling, and arguing that Trump was going to repeal the Inflation Reduction Act. Nah, I don't think so. At least I didn't think he would. I thought he might make some adjustments to it. And he did, but not in the direction that most people would speculate that he did. He didn't do much at all. But here's what he did do. Number one, in the IRA, they wanted to start to include GLP-1 drugs this year. Nope, that's not happening. Right? Wegovy, whatever, I can't even remember all of them. All the drugs, the GLP-1 drugs that help you lose weight, they are not covering them still for weight loss. Diabetes, covered. Right? Period. So that's not going to be part of the drug price negotiations. But what is changing? The prescription payment plan update. They have a couple of minor changes on that. Number one, the prescription plan update one is an automatic renewal. So beginning in 2026, if you participate in the MPPP, the Medicare Prescription Payment Plan, you will be automatically re-enrolled the following year unless you opt out. Pretty simple. Also, a separate renewal notice must be sent after the end of the annual election period and include the payment plan's upcoming terms and conditions. Right? So they're saying pretty simple. At the end of 2025, if you're already enrolled in the MPPP, we're going to automatically enroll you, but you have to get a separate renewal notice that gives you the option to opt out, and it has to show the upcoming terms and conditions for the next year. Fairly simple. It goes on to say, if you decide to opt out, CMS will require plan sponsors to process opt-out requests within 3 calendar days rather than the originally proposed 24-hour to reduce administrative burden. Nothing big there. One other thing that's not listed in here. I don't know why it's not listed in here, but it's definitely part of this. The other thing they are doing is they are requiring the carrier to write off unpaid payments, right? So if you're a Medicare beneficiary and let's say you're in Humana's plan today, right? And you live in Travis County, Texas, which is part of Austin, but then you move to Williamson County, Texas, also part of Austin, but your plan is not offered and you end up moving, and let's say you bounce carriers altogether. Let's say you have Humana here, and then you jump to Baylor, Scott, and White when you move up to Williamson County, and you were enrolled in Humana's MPPP, and they fronted all the money for your drugs for the year, and now they're billing you. But then June, you quit paying for whatever. Let's just say you quit paying regardless. Doesn't matter. CMS has required that those carriers write that off as bad debt. They cannot put the beneficiary into collections for that money. Just got to just write it off, whatever. I don't even know what the hell a write-off is, but they do, and they're the ones doing it. Number 2, cap on Part D prescription drug expenses indexed for inflation. Many of us are familiar, it says here, with the inflation indexing on our tax returns every year. Certain limits, such as how much you can contribute to an IRA, they're adjusted for inflation, but that doesn't mean it will necessarily change every year. Pretty simple. So in 2026, the cap on out-of-pocket prescription drugs is going up to $2,100. Fairly simple, right? So a little bit of an indexing change there, but again, it is a $100 increase. So everybody that you've been telling gets a $2,000 out-of-pocket max on the drugs. It's going to be $2,100 next year. Not a monster change, but it is more money. Pretty simple. Number 3, limit on special supplemental benefits for the chronically ill for Medicare Advantage plans, right? And it says here, we all know this, Medicare Advantage plans are known for the extra benefits they provide to their subscribers. Some MA plans tailor the special benefits based on the enrollee's medical condition, which is kind of how it was supposed to be designed. The CMS finalized and codified a non-exhaustive list of non-allowable supplemental benefits that are on offer under the special supplemental benefits for the chronically ill category, SSBCI. In the final rule, CMS adopted the non-exhaustive list of non-primarily health-related items or services that do not meet the standard of having a reasonable expectation of improving or maintaining the health or overall function of the enrollee. That is a lot of words to say very simply. They don't want supplemental benefits, especially for chronically ill, that don't improve your health, your standard of living, your health outcomes. They want 2 things. If you're going to put some sizzle and pop on your MA plan to make it look sexy, it needs to be the type of benefit that improves health outcome, and also the type of benefit that will have very high utilization rates. This was proposed under Biden's administration. Trump is 100% picking it up and moving forward with it. I, for one, think it's a great rule because I am tired of losing my beneficiaries to some silver-tongued call center salesman that can convince people that they need a new set of golf clubs that Aetna's going to buy them, even though that plan no longer accepts their doctors, charges them more for drugs and whatever, right? So here's a list of items or services that may not be offered under the SSBCI. Alcohol and tobacco, cannabis products. I'm surprised any of those 3 were even on the list in the first place. I can't imagine they were. If there's an MAPD out there that's giving me free alcohol, tobacco, and cannabis, sign me up. Non-healthy food, life insurance. Can't have life insurance, of course. I don't think I've ever seen that one. Can't have hospital indemnity insurance included. Funeral planning expenses, that's all fairly standard stuff. Procedures that are only cosmetic in nature. Broad membership programs inclusive of multiple unrelated services. That one is fairly gray. Don't know what all that means, but I assume that means your different gym memberships, right? Free golf clubs from Aetna, things of that nature. A lot of these are pretty simple stuff, right? None of this is, I don't think, has ever been available as a supplemental benefit. So I feel like this is kind of dumb to even mention those. This is the one they're going after, and they left it super gray here. So I'm hoping they'll tighten that up more to kind of give us an idea. But the truth is, again, looking specifically at CMS's final rule that got approved right after we got back from Medicarians. There are 2 big concerns. Again, if you're going to put supplemental benefits on your MAPD, they're going to give you 3 things. We want, number 1, it's got to be something that would help improve health outcomes. 2, it needs to have a high utilization. 3, they want the carriers to report back on that utilization, right? So all of that stayed in. They didn't get rid of any of those little pieces. That was Biden's proposed stuff. Trump carried it through pretty simply. Moving on. Insulin costs are capped. They've already been capped, but they made a tiny adjustment to it. Nothing major, right? Insulin costs for Medicare beneficiaries were capped at $35 per month or less in 23, depending on negotiated or maximum fair prices, right? The cap will now apply annually beginning in 2026. Couple of minor adjustments they made. It's basically still going to be $35, but what they did for 2026 is it's the lesser of one of 3 items now. Either $35, 25% of the maximum fair price established for the covered insulin product under the Medicare drug price negotiation program, right? So whatever price they negotiate for Mounjaro as an example, or whatever drug it might be, Mounjaro might be a bad example, let's say Novolog, they are, if 25% of that negotiated price is lower than 35, they'll give them that one, right? Or 25% of the negotiated price of the cover lens and product under the standalone prescription drug plan or MA plan, right? So even without the negotiations, if 25% of the drug price is cheaper than 35, you're going to pay that. But the most you will ever pay, $35, as long as it's on formulary. So nothing new and magical there. Zero cost sharing for adult vaccines. Completely push that one through. All vaccines are free, period. You go look at all of them, doesn't matter. Measles, shingles, COVID, whatever. If you're a Medicare beneficiary, all vaccines are free, period. No changes, right? As we already know, review your plan annually. So those are the 5 primary things that are changing next year. Again, not a lot, truthfully, pretty simple stuff. Nothing that we as beneficiaries can't handle. I think the biggest things that we're going to experience is, again, going back to these carriers that are, or I shouldn't say carriers, but these rules that are now pushing birthday rules in all the states that are going to drive up Medicare supplement cost. Christian Brindle was just talking about it in his group, that the Medicare supplement market is falling apart, for lack of a better word. I don't know that I think falling apart might be a little dramatic, but it's definitely becoming less attractive in some states. Texas, still smoking hot in Texas. You can get your plan in for $75 or cheaper down here. But if Texas ever goes birthday rule, and I can't imagine it will, that $75 plan in is now going to be probably what, $1.30? It's probably going to close to double in price, I would bet. We'll see. So that's the news for today, guys, man. I hope you all enjoyed that. I hope you got a little something out of it. I still believe in what everybody at Medicarians really hit on, because one of the things that was interesting about Medicare is, even though it was an outstanding event, very well put on, very highly attended, something like 3,800 registered agents showed up. A lot of the breakout sessions, they didn't have this information. They're like, well, we're bullish on the future for Medicare, but we just don't know what it's going to look like because they're still waiting on these final rules to come out. And then right after we get back from Medicarians, boom, Trump dropped or CMS dropped the final rule, period, like done. And then they dropped the MA payment rates, which, if you haven't heard, are going up 5.06%. Second largest increase in the history of Medicare Advantage. Joe Biden set the record at 8.5%. And then Trump's coming back with a 5.06. So we're going to see, I'm really interested to see what the plans look like this year. Normally, I would tell you that anytime we get a 5% increase in Medicare Advantage payment rates, we're going to see a handful of things. We're going to see more benefits. We're going to see a much bigger footprint, and we're going to see higher commissions. This is the only time that I would ever doubt my confidence in that statement. I've been saying that exact 3 things every time I've seen an increase in payment rate since 2014, when they really kicked off. And that was the first cycle of payment adjustments that started getting made to Medicare Advantage plans. And there's been an increase in subsidy every single year since 2014. So again, when I tell you that it's a bipartisan effort to drive people into privatized versions of Medicare, that's all the proof you need, is that every single president, starting in 2014 with Obama, has been cranking up the money into Medicare Advantage plans, some at higher rates than others. Michelle, I will get those links back into the insurance Facebook group. So look for those. I'll get a lot of these shared for you so you can pick through them and check them out yourself. I'll have those done probably here in the next 30 minutes to an hour. Where was I? But yes, they are certainly pushing in that direction. So that is just kind of more proof to it. But moving on, man, have a great, awesome day. It is Tuesday. This is how I do it. We're going to have some more news next week. I'm working on, if you guys saw in the group, I am working on a conversation. I know Lisa Asmussen is super interested in this, and I know others are as well. I'm working on getting a conversation together with another person similar to me that employs W-2 agents back here. And we want to talk about, because I don't want to just do it myself and tell you how I look at it. I want to bring some counterintuitive people in, maybe some people that are ahead of the curve, have some bigger teams, a little more success than I've got, to talk about W-2 agents, managing W-2 agents, right? In the thought process of their productivity. Actually, let's do maintaining high standards, but also productivity and profitability, because I can see the gray areas. And like, once you find an agent that's profitable, hey, if he figures out how to have high standards, that's on him. But I can see a lot of problems in there. So I want to discuss that with someone that's either immediately learned to conquer those issues or is still working their way through them as well. So that should be a great conversation. And then mark your calendars. Mark your calendars if you're in the life insurance industry, because May 27th, 2 weeks away, we're going to duke it out with the life insurance debate. I'm going to bring two high producers on in the life insurance space that have differing philosophies. One of them believes that the only life insurance you should ever buy, for the most part, is unless you're buying final expense, right? But if you're buying higher level policies, $200, $500 million policies, you should only ever buy term and invest the rest. And now bringing another guy on that disagrees and says, no, sure, term has its spot, but whole life, IULs, like all of those, that's a better play for some of those higher things. I'm just here for the engagement. But look forward to that one. That is going to be a hot debate. I'm super excited about it. That's May 27th. And as soon as I find my other guy that wants to participate on the W2 conversation, I'll get it promoted, let you guys know, and that's going to be another great one. So have a great day. Have an awesome day. Have an awesome week. We'll see you next time for Tuesday training.